a 52-year-old male presents with acute onset of high fever, productive cough with rust-colored sputum, and left-sided pleuritic chest pain. I am showing you his posteroanterior and lateral chest radiographs. Describe the findings.
The chest radiographs demonstrate a confluent, homogeneous area of airspace opacification in the left lower lobe. This opacity obscures the left hemidiaphragm but preserves the left heart border, indicating a left lower lobe localization. There are prominent air-filled, tubular branching structures running through the consolidation, representing classic air bronchograms. The findings are highly characteristic of acute alveolar consolidation, with left lower lobe lobar pneumonia being the primary diagnosis.
What is the clinical significance of an air bronchogram sign? And what are the 5 substances that can fill the alveolar spaces to produce an airspace consolidation?
The air bronchogram sign is a highly specific indicator of parenchymal lung disease, confirming that the process is located within the alveoli rather than in the pleural space. The 5 general substances that can fill the alveoli are pus in pneumonia, water in pulmonary edema, blood in alveolar hemorrhage, cells in neoplastic processes like adenocarcinoma, and protein in pulmonary alveolar proteinosis.
What is the most common causative organism for lobar pneumonia in an immunocompetent patient? And what is the critical follow-up imaging protocol for a patient of this age presenting with pneumonia?
The most common organism is Streptococcus pneumoniae. The critical follow-up protocol is to obtain a repeat chest radiograph in approximately 6 weeks after starting treatment. This is essential, particularly in a patient over 50, to verify complete resolution of the consolidation and ensure there is no underlying obstructing endobronchial neoplasm that presented initially as post-obstructive pneumonia. I would recommend initiating empirical antibiotics and scheduling the follow-up film.